Good morning. Welcome to CHEST Clinical Perspectives webinar on precision medicine, adoption of emerging methods of evaluation and therapy. My name is Mark Rudzinski, and I'm the lead researcher for the Clinical Perspectives series of white papers. CHEST Clinical Perspectives white papers contain insights and opinions gathered from pulmonary and critical care physicians on issues related to the state of practice of CHEST medicine. Clinical Perspectives is produced by CHEST Analytics, with insights on more than 30,000 of the top CHEST medicine professionals in the United States, as well as access to CHEST's exclusive key opinion leaders. CHEST Analytics is a leader in healthcare intelligence focusing on pulmonology and critical care medicine. We are fortunate to have on our research team here today Dr. Nichole Tanner. Dr. Tanner is a lung cancer pulmonologist at the Ralph H. Johnson VA Hospital with a joint appointment as Associate Professor of Medicine at the Medical University of South Carolina. Her research and clinical interests focus on lung cancer screening, disparities, pulmonary nodule evaluation, and the staging and diagnosis of lung cancer. Dr. Tanner, thanks. Our topic today is precision medicine, adoption of emerging methods of evaluation and therapy. The origin of the idea behind this issue of Clinical Perspectives is rooted in exploratory research that CHEST conducted in 2018 with pulmonary fellowship program directors and current fellows to understand the extent to which immunology, biomarker testing, and the use of biologic agents for treatment of severe asthma had become part of the curriculum. While these insights were used to guide the development of CHEST Severe Asthma Fellows course, they also raised questions as to how frontline clinicians were learning about and deploying these emerging therapeutic approaches, a task which our Clinical Perspectives vehicle is well suited to address. Thanks once again for attending today. We are taking questions during the webinar, which we will address at the conclusion. If you want to ask a question, please submit it through the desktop or mobile application on the question dropdown. With that, let's begin our presentation. Just by way of some background, Clinical Perspectives is overseen by a team of leading clinicians that provide expert guidance and advice in the development and interpretation of the results that we are presenting here. Dr. Clay Cole from Mayo Clinic is the chair of this task force, and he is assisted by a group of talented and highly regarded panelists from across the United States. That the role of the panel is to help with the identification of topical areas to explore, as well as to guide in the actual issues we explore in each one of these issues. Their involvement and their commitment is critical to the success of Clinical Perspectives, and we do appreciate their time and effort to that in that regard. To give you a sense of the agenda for today, we're going to give a brief overview of the study, the methodology, what we covered. I'm going to kick it over to Dr. Tanner then, and she's going to walk through the detailed findings from the survey, as well as to provide her interpretation and some discussion around the results, and then we'll open it up for questions from our participants. As we mentioned, the topic of precision medicine had kind of emerged as a result of some qualitative work that we had done last year, particularly around severe asthma, but it did raise a series of questions, a host of issues in terms of the extent to which existing fellowship programs were going deeply into some of the issues around these emerging therapies. And we kind of made a mental note at the time that this would be an excellent topic to explore with the Clinical Perspectives, with an upcoming issue of Clinical Perspectives. And so that's how we've kind of come to our discussion here today. The objectives of our study were very focused. First, just to kind of understand some of the nomenclature that's being used here. Is it precision medicine? Is it personalized medicine? Is it genetic medicine? There's a lot of terminology that flies around, both in terms of common language as well as some of the marketing communications that are deployed by industry, by health systems. Secondly, we wanted to assess the knowledge and the familiarity that frontline clinicians have with regard to key facets of this therapeutic approach. And lastly, we wanted to understand the extent to which utilization and the adoption of biomarker testing and emerging therapies is being taken up by the professional community as a whole. And so those are the overall objectives that we were looking to inform through this survey. By way of methodology, we conducted an online survey with a random sample of just under 100 pulmonologists. We randomly sampled these docs from the CHEST member database and fielded the survey back in the end of March and early April. So we've got some data here that's fresh off the presses here. Analytically, we looked at descriptive statistics across all of the results here to get an understanding of knowledge, attitudes, and behaviors on this particular issue, and then certainly looked at key differences within cross sections of the survey sample to understand how different categories of physicians were adopting, using, not using, or identifying barriers to use as it relates to precision medicine. Okay. The profile of our respondent base here is a cross-section of our field. As you can see on the left, 3/4 identified as general pulmonologists, 18% identified as intensivists, and we had 8% interventional pulmonologists participating in the survey here. By practice setting, it's pretty heavily skewed toward community-based practitioners, almost really by design. We wanted to get outside of the academic environment and see how frontline practitioners who are spending the bulk of their time in clinical practice, seeing patients, we wanted to understand their perspectives and the extent to which they're beginning adoption of some of these new therapeutic approaches. And then in terms of tenure, you can see that there's a pretty even mix of physicians based on 15 years or longer since their training, or less than 15 years since their training. Content-wise, before I turn it over to Dr. Tanner, just wanted to give you a sense of the issues that we specifically explored here. We started off by taking a look at language and definition as it relates to precision medicine. Secondly, we looked at some issues related to clinicians' overall familiarity with some of the core topical areas under the umbrella of precision medicine. We examined the comfort level that respondents had in terms of deploying these techniques with their patients, and also looked at the utilization of these techniques, as well as perceived barriers to adoption or reasons why uptake is not perhaps as fast as it could be. Lastly, we looked at the application of precision medicine techniques under specific diagnoses, namely asthma and lung cancer. Once we got through the initial sort of open-ended exploratory part of this survey that covered language and definition, we did provide a definition of precision medicine for respondents to work with through the rest of the survey. And I'll leave this up on the screen just for a second here so that you can kind of see the reference and the specific definition that they were working with. Okay, with that, I'm going to turn it over to Dr. Tanner to walk us through the key findings from the survey. Dr. Tanner?
Thanks, Mark, and thanks to everybody who's joined. It's a pleasure to be part of this project. I think that the findings are pretty interesting and should inform how we move forward in educating folks that are on the ground trying to use this new type of therapy and type of medical practice. So this slide here highlights what I'm going to show you in the next few slides. This is just kind of a summary, and I don't think it'd be surprising to anybody here on the call that there really is no consensus about what comprises what the definition of precision medicine is versus personalized medicine. And so if you look at this slide, it's rather busy, but if you take that third column there, association with neither term, you see the vast majority of folks really don't use either of these terms or don't associate these terms with any of the things that we're asking about. But there is a substantial minority, if you look at that far right blue bars there, anywhere from 17 to 36% that use these terms interchangeably, which just goes to show that there really is no consensus about what comprises either of these. Now, if you look at that first column, the association with personalized medicine, there were some trends that came through. And what we found was that personalized medicine tended to be associated with more patient-doctor relationships, including things like making decisions for treatment based on patient preferences and really engaging in shared decision-making about the choice of therapy. Those are the ones that kind of stood out to us. And then if you move to that second column, association with precision medicine, what we saw is that there tended to be some core clinical actions. And so it looked like pulmonologists that were surveyed, you really thought of precision medicine as something that should be applied to clinical actions or items of patient workup. These things include tailoring medical treatment to individual patient characteristics, or classifying a patient into a subpopulation that might differ in response to treatment, the use of biomarker testing to evaluate response to treatment, and even identifying patients who might be more susceptible to a disease. And so it was those core clinical actions and testing that precision medicine applied to, while personalized medicine tend to be more of a human type relationship. You go to the next slide, please. So the next slide talks about the terminology that pulmonologists actually use when talking to patients about precision medicine. And a large proportion of the survey respondents really indicated that they don't use either term. They don't say personalized medicine or precision medicine when engaging in conversations with their patients. Next slide. And not surprisingly, given the newness of this field, physician respondents indicated that less than half of their patients were familiar with the concept of precision or personalized medicine, and more than half of them ever used those terms. So I don't think that this is really surprising to us. Next slide.
Yeah, one question I had for you, Nichole, is, as the data shows here, the nomenclature really isn't established yet, and despite the fact that we see it out there in marketing communications for a lot of different audiences here. In your practice, how do you introduce the concept of diagnosis and therapy, based on precision medicine, especially when patients may be coming to the table with, in your case, with lung cancer, it's chemo, it's radiation, it's these sort of like blunt, indiscriminate tools that are going to be deployed here. How do you walk patients through what this whole approach is about?
Sure, I think that's a really great question. And as you mentioned, I mainly see patients with known or suspected lung cancer, and my job, as many of the pulmonologists on this line, is to really take them through that initial fear of not knowing what they have, getting them to a diagnosis, and then ensuring them that they're going to get the best possible treatment. And so, as everybody knows, most of the folks that we diagnosed prior to the advent of lung cancer screening were with advanced stage lung cancer. Oftentimes, the only treatment available is chemotherapy or chemo and radiation with poor outcomes. And many people come to the table, patients that is knowing this, or they're very afraid and scared. And so I find in my practice the best way to introduce this at the onset is to kind of explain, what the purposes of staging are, why we need to get tissue for diagnosis, so we know what kind of cell type it is. But then I take it a step further and I introduce this concept of precision medicine. And so I explain, not everybody's tumor is the same. There are additional tests that we can do. Based on those test results, we might identify a medicine that would target your specific tumor and give you a better chance of survival. And when you start using things, I think that really individualize the treatment and highlight that. I often use these terms as this, this is the new concept of precision medicine, where we're not just treating cancer in general, but we're treating your cancer. And we have all of this testing involved. And we need to make sure we get enough to do all of that. So that we can give you the best possible chance. And so I think that, for me anyways, when I'm dealing with a patient who has stage 4 lung cancer, I think it provides a lot of assurance. I mean, I'm sure there are many patients that stop hearing me the minute I say that. But I think for the families that are, trying to be motivated and look towards the future and come up with a game plan, it's really nice to have something tangible to hold on to. Yes, we're going to do this testing and we're going to have those results so that the oncologist knows what to do. So I think it provides comfort, and that's how I use it in practice.
Thanks.
Yeah. So moving along, talking about the adoption of precision medicine, and I think this slide and the next are kind of interesting. And so you see here that more than half of the clinicians that we surveyed use precision medicine either most or all of the time, and the majority, if you put them all together, some of the time. It's interesting that there's absolutely no difference in adoption of precision medicine techniques by time in practice. And if you go to the next slide, even though people are engaging and using these techniques most or all of the time, not many, only 16%, feel very comfortable with using these techniques in their practice, whether it be for diagnosis or therapeutic selection or any of the things that we just talked about. And over a third of patients or participants were not comfortable at all. And so that kind of begs the question, if we're using these techniques but we don't feel comfortable with them, how can we make clinicians more comfortable, and why is it that they're not more comfortable? And so that kind of led to some of the questioning that we'll talk about here in a second. Next slide. And so if you look at how the respondents what their objective was for using precision medicine. Overwhelmingly, they indicated that determining the best therapeutic option is one of their objectives, so 89%. And when you asked clinicians to pick the single most important reason for using precision medicine, I think it was something around 73% chose determining the best therapeutic option. That was followed closely by establishing a diagnosis, evaluating treatable traits, and on down the road there, with the lowest being determining eligibility for a clinical trial. If you go to the next slide. So we talked about people feeling not very comfortable, and so what is the biggest barrier to using precision medicine in daily practice? And overwhelmingly, as you can see, 87% said that it was a limited knowledge as to whether or not the newer therapies were more effective than current ones. And so I think this indicates a knowledge gap that can be addressed moving forward as we try to educate folks out there that are trying to deploy these. I think other really important, maybe non-knowledge, non-clinical related or non-knowledge related things that are the next one here: difficulty getting insurance approval for new agents. Certainly, clinicians may be excited about using these things, but we don't want the patients to have to foot the bill. And there might be some lag time for where insurance companies will cover the latest therapies, and that can become problematic, especially in a busy practice, to try to get authorization for the latest and the greatest. I think it's important to note a third of participants indicated limited access to genetic molecular testing, and this kind of speaks to some of the things I do in my daily practice. Perhaps if you're practicing in a smaller clinic and you want to send these genetic mutations and there's not a lab around that does it, you know it's the right thing to do, but you're limited with what your resources are. And I think the next one there that's listed as a potential barrier are concerns that the patients may have about the safety and effectiveness of new agents. And that's really important as new therapies come out, to be able to explain to patients the side effects. And if we don't have knowledge about all those, or we're not quite sure, it might be a harder sell. And we'll move to the next slide.
Yeah, one thought,
Sure.
I referenced the qualitative work that we did last year with fellowship program directors as well as fellows. And one of the comments that was a theme in some of those interviews from the fellowship program directors themselves were that, they didn't necessarily feel that they, certainly some programs had a go-to expert on this, was deep and was deep involved in research and clinical trials, et cetera. But in a number of programs, there was a feeling that there really is no go-to expert on precision medicine. Now, again, this was within the context of severe asthma. There really wasn't a go-to expert on this. And as one respondent mentioned, I kind of feel like we're 3-4 weeks ahead sometimes of where the residents are, or the fellows are, and they are, out there looking to learn this stuff. They know it's an emerging treatment area here, but by the same token, the faculty oftentimes is kind of learning it just a little bit ahead of where the fellows are. So I think the knowledge piece is a deep issue, as evidenced by the 87% that feel that they're lacking in this area.
Yeah, I think you're right on spot there. Even, in the academic BECAs, we're all kind of siloed. And so while, some of us focus on different disease states, what's happening in cystic fibrosis is not on the front of my mind. And so I think general pulmonologists that are out there in the community are really expected to know all of this, or know a little bit of this across all disease states within pulmonary. It can become really time-consuming and tricky, especially if you've got a busy practice. And so moving along, this slide here is a little busy again, but it just kind of tells you about how the physicians that participated in this survey really gauged the familiarity with the different pieces here. And overwhelmingly, people are in the middle of the range for somewhat familiar, not all that familiar. Very few are very familiar, although those that were very familiar, the highest proportion of that was as far as new biologics for targeted specific diseases and conditions. And I think that makes sense because we're treating diseases all the time. And if there's a new targeted therapy, I think that is more exciting to patients. You can see down below in things like guidelines and protocols for biomarker testing and treatment planning, very few folks were familiar or strongly familiar with those types of things. How to make changes to treatment plans based on follow-up biomarker testing was also something that had very few participants noting that they were very familiar. And a third of participants were not too familiar with appropriate progression in patient workup to increase likelihood that insurance will cover specific targeted therapies. And this just kind of speaks to the barriers that they noted before. I don't know, Mark, is there anything else on this particular slide that you found interesting?
A couple of things. One, again, to the point you made earlier, where we've got about 55% who report using precision medicine with most or all of their patients. Again, the dichotomy around of that statistic against the percent here who are saying that they're very familiar with some of these core issues. There's some huge gaps here. I think that middle group of somewhat familiar, in some ways I kind of discount that as being sort of like the familiar-ish group, but it's really that hardcore dark blue component here, and you can see that there's a lot of work to do here in terms of deepening the education. The other thing that struck me here is it seems like there's a lot more application on the front end with initial diagnosis, but that tends to peter off when you get further into the process where maybe you need to evaluate therapy downstream or make mid-course corrections to therapy based on how the patient is responding to it. I think we're seeing less use of precision medicine and less familiarity with how to do that in comparison to just how to apply the techniques in the initial diagnostic phase.
Yeah, I think that's true. In the front end, I think people are more familiar, but it's as, maybe the patient's not responding, we have to switch courses, as you said, to use precision medicine to help aid in that is probably, as evidence here, something people are less comfortable with. And so we talked about knowledge being a big problem. These are the resources that the participants identified as how they expand their knowledge. Medical journals was 88%, not surprisingly, but clinical reference tools such as UpToDate, 78%. And I think that just speaks to the on-the-go nature of busy pulmonologists. It's good to see that interactions with other colleagues in different medical disciplines is helpful as a way to expand knowledge. And certainly it's good to see that the CHEST meeting and communications from CHEST is helpful. And I think it's interesting, that a lot of, and maybe not surprising, that a lot of clinicians note getting information from the pharmaceutical company representatives as a way to expand knowledge on medications. And I guess that's not too surprising. And so I guess we'll switch a little bit now to the discussion, which has been going on a little bit during the way. So I think this survey study of 99 practicing community-based pulmonologists really showed us that nomenclature in our field is not established. I think we found that clinicians use a variety of descriptors to explain the category as a whole, as well as specific facets of the workup and the treatment, including personalized medicine. What we didn't share with you today were the results of the questions as they related to severe persistent asthma and non-small cell lung cancer. But what we did find is that adoption of precision medicine certainly varied by clinical area, with most folks being more comfortable or utilizing precision medicine, I should say, in the non-small cell lung cancer arena versus the severe persistent asthma arena. Utilization of precision medicine techniques appear to far outspace familiarity and comfort levels with the category. And I think, as we've kind of highlighted along the way, that's an area where we can seek to help clinicians feel more comfortable and get the knowledge that they need. Next slide. I think there's one more slide after this. Okay, and so just as we alluded to, some educational opportunities. I think that we know that our community of pulmonologists has an interest in understanding and practicing precision and personalized medicine, but they're not completely comfortable with it. As pointed out by the focus groups and just from what we're gathering from this survey, there's a lack of medical education in this topic because it's new and it's evolving. There's a new article in the New England Journal practically every week talking about a new biomarker, a new drug therapy, at least in the non-small cell lung cancer treatment. And so it's hard to keep up. And I think this is an opportunity, given CHEST's resources, to help expand education. There's a lack of knowledge about effectiveness of new agents, and this was cited as a common barrier to adoption. Why are we going to adopt something if we're not fully convinced that it works? And so I think this, again, is another unmet educational need. Clinicians have really indicated that they're interested in education to help them apply these advances. I don't think there's any practicing clinician out there who wouldn't want to know about these things. It's just a matter of finding the time and delivering the information in a way that they can digest quickly and in a way that meets the busy needs of their practices. And as we mentioned before, another significant barrier that's not really related to the knowledge is the payer concerns and clinicians not understanding exactly what they need to ensure that there is coverage for these precision or targeted medical therapies. And I think with that we sum up all of the results, and I think the next slide is to open it up for any questions.
Yeah. Let me just go over there and see if we've got anything that's come in here. One question. Let me just try to interpret it here a little bit. And a couple of different points we talked about really the gap between people who are doing this and how comfortable they feel they are about doing this or knowledge about doing this. Are there other models out there that we can look at, whether, it's a new therapeutic approach that's been introduced to the discipline or a new diagnostic modality that is changing the way that we work up or evaluate a patient? Is there anything else in the introduction of other new approaches and modalities that we can learn from and apply to speed the advancement of uptake here in our professional community?
I think that's a great question, and I think it applies to all of medicine, really. Something comes out and, there are early adopters, and there's a nice little, I don't know if it's a conceptual model that talks about even when you talk about adoption of new technology, bronchoscopy, all of those, there's the early adopters, people that get really excited about things. Then there's the, kind of midway, and then there's the late adopters. And, I think some of that is personality-based and skepticism. How do we get the word out? And that's really an implementation science question for anything. I mean, it can be applied to something like lung cancer screening and its adoption or lack thereof. I think by way of precision medicine and these therapies, really the end user or the person that needs to adopt is the clinician. And so how do we ramp that up? If I had the answer, I think that I'd be a very wealthy person. But I think that guidelines are really helpful. I think when some of these things become part of the guidelines, I feel like there's a sense, and this is just my gestalt, I feel like there's a sense that if something's in the guidelines, then it's evidence-based, and we assign in a very rigorous way the level of evidence that goes along with that guideline recommendation. As far as cancer care goes, guidelines like the NCCN get updated with each New England Journal publication as to whether or not to include or incorporate this new therapy for stage 4 lung cancer or small cell. Now there's an indication for immunotherapy up front. And so the guidelines are like a living guideline, and they change as the new data comes out. And so I think having resources available that are up to date, that are readily accessible to clinicians, that they know about, I feel like most pulmonologists see severe persistent asthma, see lung cancer patients, but we have to know what do we need to do from our side. And so I think, the oncologists have a very good tool in the NCCN to get the latest and the greatest on precision medicine. We just need to figure out how we fold. And I think it's really dissemination, through the web, through educational seminars, through, just individuals coming around. I mean, they noted the drug reps as folks that are informing them about this new stuff. So I don't know, it's an implementation question, and I think every clinician is different and is shaped by the type of patients that they see. And if we knew how best to implement all of these things, we wouldn't be writing about how people are not guideline concordant. So I think it's just tricky.
Another question that came through here, and it probably fairly closely related. Again, knowledge was identified as a significant barrier here, as well as the extent of familiarity on the front end, the diagnostic side, initial diagnostic phase. Familiarity levels were a little bit higher there than when we looked further on at some of the treatment aspects of it and evaluating that treatment. And again, I think this closely follows on your previous comments, but does it surprise you that, knowledge seems to be a little bit better, or there seems to be a little bit more comfort with one aspect of this, but, we're not necessarily, the field may not be necessarily taking a holistic view of applying this approach kind of throughout the care process and not just at the outset?
I guess it's not surprising because as I think about it, I don't know that there are items of precision medicine that you can test in the journey of someone being treated. For instance, I'll just keep going back to lung cancer because that's what I know. If you have somebody with an EGFR mutation that then progresses on targeted therapy, we need to rebiopsy to check for a T790M mutation, which is a resistance mutation. And so that would alter therapy and then guide therapy. Now, there are folks out there with asthma, severe persistent asthma, that might get started on a biologic. Is there really something that we test for all the time to see if we need to change or response? I think people are more comfortable testing, different tumor markers for certain cancers, and that doesn't really apply to the pulmonologist. And so I think there's very few interim tests that we're doing to assess response, other than the patient is feeling better, that have really made it to prime time and are out there for folks to consider. So I'm not surprised by that. I think we rely a lot on our colleagues from other disciplines that might be managing things with us to say, oh, hey, this person has progressed. We need to retest this. You think you could help us by, doing the bronchoscopy, and make sure you send it for this. And so then we learn as we go along. But to answer the question, I'm not surprised that the, intermediate or let's check up and see how they're doing with biomarkers or additional precision type tests haven't, really been taken up, because I just don't feel like there's that many of them, if that makes sense.
Okay. And for our webinar participants here, are there any other questions that you would like to ask of Dr. Tanner? Again, please use the drop-down box and type your question in, and we'll forward it along. That looks like that's it for the Q&A component here. Dr. Tanner, thanks very much for doing this. Are there any final thoughts that you have with regard to this issue and some of the things that you took away from it?
Yeah, well, thank you for having me first, and thanks for everybody for dialing in and listening. I guess, my biggest take-homes are kind of what we've harped on is that, there's a big gap in how many people are using it. And remember, only 50% really are applying these all the time. And so I guess I would just say that we need to work on finding ways to educate the spectrum of pulmonologists, from those in training to those that are out in practice, in ways that are time friendly and provide the information and provide comfort that what they're doing is the right thing to do. And I think it's an exciting time, and we all need to just be open as clinicians to changing our ways if something comes along that might benefit our patients, and spending a little bit of time trying to learn about it. That's all.
Dr. Tanner, thanks so much for your time, as well as kind of your insight and guidance throughout the entire process here. If anyone is interested in learning a little bit more about this survey, Chest Analytics does have an entire white paper that it has been published containing all the data in the study. And if you're interested in seeing that, please get a hold of Chest Analytics, and they will follow up with you. Again, everyone, thank you for taking the time this morning to participate in this issue of Clinical Perspectives. Have a good day.